Imagine this. A foal, seemingly healthy, full of life one day, then suddenly just struggling to breathe. Or even worse, succumbing to an illness that seems to just strike out of nowhere. It's a devastating reality for horse breeders all over the world, and it's often driven by this stealthy bacterial infection known as Rhodococcus equi. So today we're diving deep into this really persistent challenge. Our mission in this deep dive is to unpack all the sources you've provided us, pull out the most important insights, and give you a real shortcut to being well-informed about this pretty complex disease.
Right. And what we'll explore, it isn't just about animal health, although that's obviously key. It's also a fascinating case study in, well, microbial science, diagnostic puzzles, and, the broader implications for how we manage diseases in a world where these threats are constantly evolving. You'll even hear about this cutting-edge proposal to rename the organism Rhodococcus equi, which really just highlights the continuous scientific evolution happening around it.
Okay, so let's start right at the beginning then. We've heard about Rhodococcus equi being a major concern in foals, but what exactly is this organism and what makes it such a, well, formidable adversary?
Well, at its core, Rhodococcus equi is a very clever, adaptable bacterium. It usually just lives in soil. You can think of it like this. It's gram-positive because of its tough outer cell wall, pleomorphic, which means it can actually change its shape, and crucially, intracellular. It loves to hide inside the host's own cells, kind of out of reach of some immune defenses. It's also a facultative organism, meaning it can survive with or without oxygen, which makes it incredibly resilient. But for foals, specifically those under 6 months old, it's an incredibly important cause of severe pneumonia, and it doesn't stop there. Beyond the lungs, it can also lead to other really serious issues like diarrhea, joint sepsis, and these sort of widespread abscesses throughout the body.
Wow. It's pretty remarkable that a common soil bacterium can become such a devastating problem for foals. How does it manage that transition from, harmless environmental thing to serious pathogen inside a young horse?
Yeah, the main way they get exposed is through inhaling dust that contains the organism. And once it's inside the foal, it's incredibly strategic. It actually lives and replicates specifically within the alveolar macrophages. Those are essentially the lung's own immune cells. This lets it evade the host's immune defenses because it interferes with the normal process of phagosome-lysosome fusion.
So it basically stops the cell from cleaning itself out.
Exactly. It sabotages the cell's internal garbage disposal system, you could say, preventing itself from being broken down and destroyed. And this internal replication is what ultimately leads to that characteristic, really severe, potentially life-threatening pyogranulomatous bronchopneumonia. It causes extensive necrosis, destruction of the lung tissue itself.
That's a truly insidious survival mechanism.
Yeah.
But what gives our equid its deadly punch? Are there specific weapons or factors that make certain strains so dangerous?
Yes, absolutely. A key revelation here is the role of a large virulence plasmid. Think of it as extra genetic instructions for causing disease. Specifically, a protein called virulence-associated protein A, or VAP-A. It's a specialized protein on the bacterium's surface, and it's considered absolutely central to its virulence. Strains that have VAP-A are highly virulent. Then there's VAP-B, which is associated with intermediate virulence, and other genes like VAP-C, D, and E.
Okay.
And what's fascinating is that the expression of these genes is temperature dependent. They turn on at the host's body temperature, 37 degrees C, but not really at 30 degrees C in the environment.
Ah, smart. So it saves energy until it's actually inside the foal.
Precisely. It's a sophisticated adaptation, right? Conserving metabolic resources by only producing these energetically costly virulence factors once it knows it's inside a host. There are other factors too, like interactions with iron, certain enzymes, sometimes called equifactors, and even a kind of protective capsule around the bacterial cell.
So it's clearly not just about the lungs then. It sounds like this organism can have a full body impact, which I imagine really complicates diagnosis and treatment.
That's exactly right. While pneumonia is the primary issue we see, the bacterium can, and often does, disseminate to nearly every other system in the body. So beyond the respiratory system, it can affect the GI tract, the musculoskeletal system, blood, lymphatics, immune system, eyes, kidneys, skin, liver, even the nervous system. And this spread can lead to things like septic arthritis, inflammation of body cavity linings, serositis, abscesses in the vertebrae, and even immune-mediated conditions.
Immune-mediated, like the body attacking itself because of the infection.
Sort of, yes. Things like polysynovitis, where multiple joints get inflamed, uveitis in the eye, or even hemolytic anemia, where red blood cells are destroyed.
Right. Okay, so for a long time, the common thinking pointed to our equid as purely an environmental problem, mostly about dust in barns and paddocks. But new research seems to be changing that understanding quite dramatically, isn't it?
Yeah, the traditional view certainly holds true to an extent. Araquora is absolutely a ubiquitous soil saprophyte. It lives off decaying matter in the soil, and it's widespread on pretty much all horse farms. Its growth gets a huge boost, like up to 10,000-fold from volatile fatty acids found in herbivore manure, especially fall manure, particularly from foals up to about 12 weeks old.
So the foals themselves contribute to contaminating the environment early on.
Exactly. They become a primary source of environmental contamination. And factors we've known about for a while, dry, dusty conditions, sandy soils, crowded areas, higher environmental temperatures, they all contribute to more bacteria being around.
But that traditional view, it's been challenged recently, hasn't it? What's the new research telling us that fundamentally changes how we should think about our equitransmission?
Well, this is where it gets really interesting and, frankly, changes the game. Recent studies have basically altered our perspective. They've shown that virulent R. equilis, the dangerous kind, can actually be detected being exhaled from the respiratory tract of foals. And this happens regardless of whether they seem clinically healthy or are obviously sick.
Exhaled, so they're breathing it out.
Yes. And what's more, the concentrations found in the air exhaled by these foals were up to 5 times higher than those detected in environmental air samples taken nearby.
Wow. Okay, that's huge. So it's not just about kicking up dust anymore.
It really isn't. The real breakthrough here is realizing that foals themselves are aerosolizing the bacteria. They can act as silent spreaders, breathing out high levels of the virulent form. It fundamentally rewrites our prevention playbook.
That is a complete game changer. So what does this all mean for how we approach prevention now? It sounds like maybe we've been focusing too much just on the environment.
It implies there's a significant and previously really underappreciated direct aerosol transmission route happening between foals. Asymptomatic foals, the ones that look perfectly fine, can be acting as silent reservoirs, shedding high levels of virulent R. equine just by breathing. So this means that environmental dust and manure control, while still important, definitely aren't the whole story. They might not be sufficient on their own. Strategies to actually reduce close contact and perhaps manage group sizes among foals might be equally, if not even more, important now in preventing new infections.
Okay, so a disease that literally hides within the foal cells, and now we know it can also spread directly from foal to foal, even from seemingly healthy ones. That brings us to another big challenge. The deceptive way this disease often shows up, or well, doesn't show up at first glance.
You're absolutely right. The onset is frequently insidious, really sneaky. Foals are remarkably good at compensating for progressive loss of lung function, so early clinical detection can be very challenging. The obvious signs might not appear until the disease is actually quite advanced, and that can lead to sudden acute respiratory distress or even, tragically, sudden death.
So what signs should people be looking for, even if they might be subtle?
Well, when signs do appear, they typically include fever, maybe 101.5 to 104 Fahrenheit, a cough, which can range from just occasional to quite frequent, sometimes moist, sometimes dry. Lethargy, depression, maybe not eating well, poor weight gain, not wanting to run around as much exercise intolerance, sometimes diarrhea or noticeable joint swelling, joint distension. And during a vet check, listening to the chest-thoracic auscultation might reveal crackles and wheezes, or in really bad areas, even absent breath sounds where the lung is consolidated.
And like you said before, it's not just the lungs that can be affected, which really complicates the whole clinical picture, doesn't it?
Yeah, it absolutely does. These extrapulmonary manifestations, or EPDs as they're sometimes called, they definitely complicate things and generally make the prognosis worse. The most frequent ones we see are intestinal and mesenteric abscesses within the gut and its supporting tissues. Ulcerative colitis, inflammation of the colon, is actually seen in about half the foals that have pneumonia.
Half.
Yeah, it's surprisingly common. Then there's immune-mediated polysynovitis, which affects roughly a third of foals with lung lesions. That typically shows up as joint swelling, often in the hocks and stifles, but it's usually not painful effusion. And then other EPDs can pop up. Septic arthritis, which is painful, bone infections, osteomyelitis, eye inflammation, uveitis, abscesses under the skin, and that immune-mediated hemolytic anemia we mentioned earlier.
Okay. Given how tricky the symptoms are to spot early and how widespread the disease can become in the body, how do veterinarians actually go about diagnosing our equio? It sounds like it requires some serious detective work.
It definitely requires a multimodal approach. You can't rely on just one thing. Clinically, the foal's age is a big clue, usually 1 to 5 months old, combined with those physical signs like fever or increased breathing effort. Blood work helps too. Elevated fibrinogen, hyperfibrinogenemia, and a high white blood cell count, specifically neutrophilic leukocytosis, are pretty consistent findings. But, and this is important, they're nonspecific indicators of inflammation. They don't scream R equi. Serum amyloid A, SAA, is another marker that tells you there's inflammation, but it correlates pretty poorly with how severe the R. equine infection actually is. So, again, helpful but not definitive.
So blood tests point towards inflammation, but not necessarily this specific bacteria.
Right. Exactly, which highlights the challenge of early specific diagnosis. And something really important to stress here is the limitation of serological testing looking for antibodies in the blood. Tests like ELISA or AGID are not recommended for diagnosing active disease. Why? Because exposure to R. equine in the environment is so common that lots of healthy foals will have antibodies anyway. Plus, maternal antibodies passed from the mare can interfere, potentially giving false positives. It's a common pitfall to avoid.
Okay, so blood antibody tests are out for active diagnosis. What does give a definitive answer then?
For definitive lab diagnosis, you really need samples directly from the lower respiratory tract, from the lungs. That means doing either a transtracheal wash, a TTW, which is a way to collect fluid from the windpipe, or a bronchoalveolar lavage, a BAL, which washes deeper into the smaller airways. Then you take that fluid and look for the bacterium itself through culture, or you look for its unique genetic signature, specifically the VAPA gene, using PCR. You can also look at the cells under a microscope cytology and sometimes see these characteristic Chinese character-shaped rods.
But even if you find the bacteria or its DNA, that's not the end of the story, right? You mentioned it can just be colonization sometimes.
Precisely. Even a positive result from a TTW or BAL needs supporting evidence, either clear clinical signs or findings on diagnostic imaging. Because R. equi is so ubiquitous, it can cause transient colonization without actually causing active disease. So context is key.
Which brings us to imaging. How crucial is that?
Oh, it's crucial, both for confirming the diagnosis, figuring out the extent of the disease, and guiding treatment decisions. Thoracic radiography, X-rays of the chest, can reveal characteristic patterns like consolidation and abscesses, especially around the hilum where the main airways enter the lungs. They're also good for monitoring progress over time. But thoracic ultrasonography, TUS, using ultrasound on the chest wall has really emerged as incredibly accurate and practical, especially on farms.
Why ultrasound?
Well, it's excellent for looking at lesions near the surface of the lungs, the peripheral lesions, and most foals with R. equi pneumonia have those. Ultrasound can identify abscesses really well. They often look like these roundish, sort of low echo structures, sometimes with dissolved walls or even gas inside. Plus, it's quick, it's relatively easy to do stall side, and it enables earlier detection of those subclinical lesions, the ones not causing obvious illness yet.
Ah, okay. And that actually leads to an interesting point you mentioned earlier. Finding lesions with ultrasound doesn't automatically mean you treat. Right.
Exactly. That's a fascinating insight that's come from the widespread use of screening ultrasound. It's led to much earlier detection, yes, but it's also raised really important questions about when to actually start treatment. We now know that many small lesions say if you add up the diameters of all the abscesses seen on ultrasound, and it's less than about 10 centimeters total, many of those can actually resolve spontaneously without any antibiotics at all.
That's a critical point. Just because you find it doesn't always mean you treat it, especially if the foal seems fine otherwise. But for the cases that do require intervention, how do veterinarians approach treating R. equi pneumonia?
Okay, so for foals that are clinically ill or have significant lung lesions on ultrasound, the cornerstone of treatment is a prolonged course of combination antimicrobial therapy. That typically means using a macrolide antibiotic nowadays. Clarithromycin or azithromycin are generally preferred over the older erythromycin because they tend to have better absorption and effectiveness against the bacteria. Combined with rifampin. This specific combination is really crucial.
Why is that combination?
Several reasons. They work synergistically, meaning their combined effect is greater than the sum of their parts. They achieve high concentrations inside the cells, remember? Erythrococcus hides inside macrophages. And they penetrate those tricky abscesses pretty well. But it is absolutely imperative, critical, that rifampin is always used with another effective antibiotic, like a macrolide. Never use rifampin alone.
Why not?
Because resistance to rifampin develops incredibly quickly if it's used by itself. The combination helps prevent that rapid resistance development.
That makes perfect sense given how adaptable this bacteria seems to be, but there's a really significant and quite concerning problem emerging even with these combination treatments, isn't there? Antimicrobial resistance.
Yes, unfortunately, this is a huge issue we're facing now. We're seeing an increasing prevalence of antimicrobial resistance, AMR, specifically to both macrolides and rifampin. On some large breeding farms, isolates resistant to these cornerstone drugs are now being found in up to 40% of infected foals. That's alarmingly high.
40%, that's staggering. What's driving this resistance?
Well, this concerning rise in AMR has been pretty directly linked to the widespread and often prophylactic use of these antimicrobials in foals that are subclinical, meaning they have lesions found on ultrasound screening but aren't actually sick.
So treating foals that might have gotten better on their own was inadvertently creating drug-resistant strains.
That seems to be a major contributing factor, yes. It points to a critical, almost ironic problem. Our very efforts to protect all foals by treating even small lesions were, in some situations, likely driving the evolution of these superbugs. It's a really stark reminder that even well-intentioned treatments can have profound, unintended consequences down the line.
That's a powerful revelation. So what does this all mean for how we approach treatment now? It sounds like there's been a profound shift in thinking, a real paradigm shift.
There really has been. It fundamentally reshapes our approach. The recognition that many, maybe even most subclinical cases, specifically those with small accesses, say less than 10 centimeters in total diameter on ultrasound, can spontaneously resolve without any antibiotics. Some studies show resolution rates as high as 88% in these cases. That knowledge, coupled with the clear link between treating those subclinical cases and driving AMR, well, it mandates this paradigm shift.
So no more treating just based on an ultrasound image if the foal looks fine.
That's the strong recommendation now, yes. Prophylactic antimicrobial treatment, treating foals without clinical signs, just because they have small lesions on ultrasound, is now strongly discouraged. Studies have shown it's not superior to placebo in preventing actual clinical disease, and it directly contributes to the AMR problem. So treatment should really be reserved for foals that show clear clinical signs of illness fever, cough, lethargy, increased respiratory effort, or those whose lesions are seen to be progressing or are already large, for example, exceeding that rough guideline of 10 centimeters total diameter. This promotes responsible antimicrobial stewardship. It's about saving these crucial drugs for the cases that truly need them.
That makes a lot of sense. Beyond the antibiotics for those cases that need them, what other supportive care do affected foals require to give them the best chance at recovery?
Oh, comprehensive supportive care is absolutely crucial. It's not just about the drugs. This includes things like providing a clean, really well-ventilated environment. Reducing dust and ammonia exposure is important. Robust nutritional support is key, making sure they maintain their intake, ensuring they stay adequately hydrated. Using non-steroidal anti-inflammatory drugs, NSAIDs like flunixin or ketoprofen, can help manage fever and discomfort. For foals with significant respiratory compromise, supplemental oxygen might be needed. And because stress can contribute to gastric ulcers, anti-ulcer medication is often a good idea too.
Right. Treat the whole foal, not just the infection. Okay, so if we're trying to avoid treating subclinical cases whenever possible, prevention becomes even more critical. What are the current strategies for trying to prevent our equine outbreaks in the first place?
Yeah, prevention is paramount. Current strategies really focus heavily on two main areas: passive immunization using hyperimmune plasma and rigorous environmental control measures. This focus exists largely because, despite decades of research, a consistently effective commercial vaccine remains elusive. It's been a tough nut to crack.
Okay, let's talk about that hyperimmune plasma first,
Okay.
HIP, right? How does that work to offer protection?
Right, HIP. The idea is to administer plasma collected from donor horses that have been repeatedly vaccinated against R. equi, so their plasma contains high levels of specific antibodies. You give this plasma intravenously to the foal, ideally within the first 48 hours, or at least within the first few days of birth. This provides temporary or passive immunity. The antibodies, particularly those against that key virulence factor VA, help the foal fight off infection during that critical early period before its own immune system fully matures.
Does it work well?
It can be effective. Studies have shown, for instance, that administering 2 liters of HIP is generally superior to just giving 1 liter in terms of protecting against the development of those subclinical lung lesions found on ultrasound. However, the reported efficacy has been a bit inconsistent over the years. Results from different studies have sometimes conflicted.
Why the inconsistency?
Several factors likely play a role, things like the age of the foal when it receives the plasma, the level of bacterial challenge on that specific farm that year, and perhaps most importantly, significant variability in the actual antibody content and potency among different commercial HIP products. It really underscores the need for careful product selection and potentially tailoring administration protocols based on the farm's specific situation and the product being used.
Okay, so HIP is one tool, but maybe not a silver bullet. What about environmental management, especially now with this new understanding of a foal-to-foal spread being so important?
Environmental strategies are still absolutely critical, even with the aerosol transmission knowledge. They include all the things we've traditionally focused on. Reducing dust is huge, wetting down dry, high traffic areas, maintaining good pasture cover. Minimizing manure contamination is also key. Regular removal of manure from stalls and paddocks, proper composting to kill the bacteria, and avoiding overcrowding, which increases both environmental load and close contact. But now, that new understanding of direct foal-to-foal aerosol transmission adds another layer. It means that strategies aimed at reducing close contact between foals, maybe managing group sizes or how foals are housed and turned out, become just as important as, if not potentially more important than, simply focusing on dust and manure. It really emphasizes the need for a multi-pronged approach to tackle the environment and the direct transmission potential.
Right, so given all this complexity, the economic impact, the welfare concerns, why haven't we developed a consistently effective vaccine yet? It seems like such an obvious need after all these years.
It's a great question, and it's incredibly frustrating for researchers and veterinarians alike. The development of an effective commercial vaccine faces some really significant biological and logistical challenges. Firstly, foals get infected very shortly after birth, often within the first few days or weeks of life, at a time when their own immune systems are still developing and may not respond optimally to vaccination. Secondly, those maternal antibodies we talked about, the ones the foal gets from the mare's colostrum, they can actually interfere with the foal's ability to mount its own immune response to a vaccine. So timing the vaccination perfectly is tricky.
Okay, immune system immaturity and maternal antibody interference. What else?
Another big hurdle has been the lack of really good small animal models that accurately replicate the specific type of pyogranulomatous pneumonia we see in foals. This makes the early stages of vaccine testing and development much more difficult. And then when you get to the stage of needing to test promising candidates in foals themselves, well, that's expensive and complex. Horses have long gestation periods. Raising foals for studies is costly, and there's inherent genetic variability. It just slows everything down. That said, there is ongoing research. Things like vaccines targeting a surface molecule called PNAG, or even novel approaches like enteral immunization giving modified live equi orally show some promise, but they're still very much in the research and development stages, not ready for commercial use yet.
Okay, so vaccine development is tough. Let's shift to prognosis. For a foal that does contract R. equi, what's the overall outlook? What can breeders expect in terms of survival and long-term health?
Generally speaking, the prognosis for survival is actually pretty good, especially for foals that only have mild or subclinical disease. As we discussed, many of those, particularly the subclinical ones, can recover fully even without antimicrobial therapy. However, the severity of the clinical disease makes a huge difference. And critically, the presence of those extrapulmonary complications we talked about, the problems outside the lungs, significantly worsens the prognosis. For instance, foals that develop severe gastrointestinal involvement, like extensive colitis or abdominal abscesses, or those that get septic arthritis in multiple joints, their mortality rates can approach 80%, even with intensive treatment.
80%. That's grim. So survival really depends on how sick they get and if it spreads.
Exactly. Early diagnosis and appropriate intervention for clinically ill foals are key, but complications are the real worry for survival.
And it's not just about surviving the initial illness, is it? What about the long-term impact on a foal's future career, especially for performance horses like racehorses?
That's another critical consideration. Unfortunately, severe R. equi pneumonia can negatively affect a foal's future athletic potential. Studies have looked at this, and they suggest that foals that were severely affected have a reduced percentage that actually make it to the racetrack compared to their unaffected counterparts. And for those that do race, their average earnings might be lower. The thinking is that the extensive lung damage and potential systemic complications can compromise their long-term respiratory function and overall health, ultimately impacting their athletic capability down the road.
So a tough start can have lasting consequences for their careers.
It certainly can for the severely affected ones, yes. If we kind of step back and connect this to the bigger picture, our equine infection in foals is really a compelling case study. It shows how scientific understanding evolves, often dramatically, when faced with these complex biological challenges. That shift from thinking it was purely environmental transmission to recognizing the major role of foal-to-foal aerosol spread, that's huge. And the crucial change in antibiotic stewardship, moving away from treating subclinical cases because of AMR concerns. It really highlights how dynamic veterinary medicine is and how absolutely vital evidence-based practice becomes.
Absolutely. This deep dive has really shown us how just one single organism can have such a profound, multifaceted impact right from the cellular level, how it hides in macrophages, all the way up to the economic well-being of an entire industry. It's a powerful reminder, isn't it, that even in diseases that seem straightforward on the surface, there are always layers of complexity, and new discoveries are constantly changing how we need to approach them. So what does this all mean for you listening in? Well, maybe next time you hear about managing any disease, really perhaps you'll think not just about the obvious symptoms, but also about those hidden factors like microbial adaptation, that delicate balance of host immunity, and the really profound ripple effects our treatment choices can have, especially regarding resistance.
Yeah, and that makes us consider maybe a final thought for you to mull over. How might the lessons we've learned or are still learning from managing our criticity, particularly that difficult balance between wanting early detection and needing to avoid overtreatment because of AMR concerns, how might those lessons apply to other infectious diseases? Not just in animals, but in humans too.